All right, welcome to our final session
What?
of the
The final session?
2025 summit. Yes, this
No
is the
way.
final session. I have mixed emotions,
Could imagine. This is your
you
baby?
know. This is my baby, and I feel like it's the first day of school and
Wow.
walking them up to the door, all of that
Shout
fun.
out to Jamie. Woo!
Thank you. Thank you all
You've
so
done
much.
such a great job.
I appreciate it, but I just could not have done it without the team, without everybody behind the scenes, everybody in the chat, all of the presentations, just everybody that has just shown so much love over the last couple of days. It's just been amazing. Oh, Elizabeth, you are
Hey,
so
Elizabeth.
you are built and you built it
We
and we
love our Elizabeth.
thank you,
Pays
Elizabeth. Yes,
attention.
we do. And so we will go ahead and get started. And I promise this is the last time that you all will hear me talk about your CEO dashboard. Remember, your CEO dashboard is your best friend, and that is where you will find everything that you need, including the completion of the summit evaluations. Please complete those evaluations and just be as honest as you possibly can. We love the feedback. We love to hear what you loved, what we need to do better on, what you would like to see in the future. That is how we grow, and that is how we continue to bring you quality presentations like I hope we've done this week and in the future. So we will get started. My name is Jamie Singletary, and I am the Senior Director of Clinical Brand and Community for Within Health. And it is my pleasure to introduce our colleagues and friends, Dr. Wendy Oliver Pyatt and Brittany Ashmore. Brittany Ashmore is a licensed marriage and family therapist who specializes in treating eating disorders with experience in outpatient IOP PHP levels of care. Brittany specializes in neurodiversity affirming care and has a strong passion for understanding and addressing the intersection of autism, ADHD, and eating disorders. Brittany has presented numerous webinars and workshops for eating disorder professionals on this intersection. She is also passionate about sharing her knowledge about the treatment of eating disorders by offering trainings to therapists in her local community. Brittany is the creator and facilitator of Recovery Unmasked within Health's therapy group for neurodivergent clients. Brittany currently serves as a primary therapist at Within Health, and she is such a superstar that we kicked off our RFID alumni space this week in the middle of the summit. And I asked Brittany, I said, if you want, we can definitely postpone this and we can
Mhm.
do it a little bit later. And Brittany said, nope, let's do it on Monday.
Mhm.
So that is the wonderful Brittany Ashmore. And Dr. Wendy Oliver Pyatt is a world leading expert on treating eating disorders with more than 25 years of clinical experience. She has developed 5 distinctive treatment programs, all grounded on a strong biopsychosocial foundation and incorporating intensive psychotherapy with behavioral foundations and high medical standards. Wendy has developed a unique treatment approach that delves into the underlying issues that place a person at risk for mental health conditions and eating disorders and lead to healing, health, and inner peace. Wendy has significant lived experience with family and loved ones who have had ADHD and autism, in addition to writing a book. And I am going to mess the title up, Wendy. You just told me.
It's okay. It's my BED book, Questions and Answers on Binge Eating
Questions and
Disorder.
answers on
Too
binge
long of a title. I didn't choose it.
No,
They
my
made me.
my brain is full. I'm so
Eh,
sorry. Questions and
It's
answers. There
reasonable.
you go.
It's too long
So
of a title.
without further ado, I turn it over to our final session to Dr. Wendy Oliver Pyatt and Brittany Ashmore.
Amazing.
Great.
Thank you, Jamie.
My job today is to mostly get out of the way because I want you guys to have time with our wonderful Brittany, who is so passionate about this work and has added so much to the care of the patients at Within Health. So I am just really uplifted to get to spend time with her in the preparation of the talk and therefore also get to be more and more in awe with her. So you're going to hear a lot from Brittany today, and I'm delighted about that. We are going to focus on three kind of clinical. There's so much. I mean, we started off with I think 70 slides, right, Brittany? And
Yeah.
we were like, okay, let's be realistic here. So we narrowed it down. So we're gonna have spend some time talking in general, and we are going to focus a little bit on a couple of areas clinically. We're going to talk about RFID. We do some really cool stuff with RFID, and Brittany's also going to do a case presentation toward the end. Actually, that's a sort of autism ARFID duo
Mhm.
patient, because the myth that the two are separate is actually a myth.
Mhm.
So she can talk more about that. So we're going to talk about ARFID, and we're going to talk about my love area is BED and ADHD, which I've been working with that population in ways back to 2003, in ways that I think are really, really powerful. And I think we do a beautiful job with that. And then Brittany's going to talk a little bit too about autism and anorexia nervosa. So those are sort of three treatment bubbles in addition to some of
Mhm.
more of the general stuff. So handing it over to Brittany, who will get us started.
Awesome. Thank you so much, Wendy. And also just, yeah, so much to go through. So we'll get started. And for some context too, just as we go through the training and learning together. I have lived experience as a neurodivergent person myself. And so I think this is where this passion for working with this intersection with eating disorders and neurodivergence really is is fueled by my own experiences as well. And so I'm just so thankful to have the platform to share this with folks across the board with eating disorder treatment clinicians and providers. It's such a meaningful thing that to have this. So thank you um, to Within and Wendy and Jamie, and also to everybody who's here to learn. I think it's such a cool thing knowing so many people are interested in better serving this population. So really
Yeah.
excited.
Brittany, one thing I didn't mention in the very beginning, which I intended to, is the field. I have this talk called Breakthroughs in Treatment. One thing we really haven't talked about is that the field for a very long time really did not do a good job at all, and still struggles to do a good job with these intersections. And I remember
Mhm.
not long ago when I got a referral from a patient who really wanted to come to a program that was a mindful eating based program, and the patient was told, you have autism, you cannot come to our program. I mean,
Mm,
that wasn't
yeah,
even, that was
yeah,
like two years ago, Brittany. So the
yeah.
field, thank goodness our field is evolving, and thank goodness
Mhm,
for somebody like you, because lived experience, there's nothing like it as far as
mhm.
informing us. So anyway, just wanted to
Yeah,
say that before you get rocking and rolling.
awesome. Thank you. Yes. So true. And I'm excited to see like what the future holds for our field and for this intersection and for better serving our clients, because so many people in care. Um, it's such an overrepresented population in eating disorder care across the board. So very, very excited for this. Okay, so just a few kind of points here as we go through the presentation. So rather than doing person first language, which is kind of a lot of times what we're taught in grad school and taught in the field, um, with autism especially and neurodivergence, a lot of times a lot of research shows that people in the community really do prefer identity first language. So that would be we're saying autistic person, ADHD, or kind of things like that, because a lot of times when you really talk to people in the community, it's very difficult. It's really not even possible probably to differentiate um, us neurodivergent humans from the way our brain works, right? And so a lot of people in the community really do prefer to and view this as part of our identity. And at the same time, people have different preferences. And so some people may not prefer that. So as providers, it's always important, like with anything, that we are really hearing what our clients are wanting and preferring and honoring that. Through the presentation, we will mostly be using the identity first language though. Also recognizing that functioning labels are something that have historically really been utilized when speaking about autism. And it's really important that we recognize that autism is not just a linear spectrum of you're more or less autistic, and that people have a cluster of different traits that are all related to their brain and their neurotype. And so a lot of people in the community have also expressed that functioning labels can be really harmful because they will dismiss strength that people who are layered or labeled with this low functioning label have, and also really minimize the support needs that can be very real for people who are labeled as high functioning. Because a lot of times the reality is that there are going to probably be areas where we may be very high functioning in some ways, but also very low functioning in others. So I think it's very important to recognize that this isn't just one linear spectrum. It's more of a cluster of traits. Okay, some terms just to be familiar with if you are not already. So neurodiversity, this is a term that was coined by Judy Singer. And this is the idea that just like any other human trait that we all have diversity in our neurotypes as well. And this is viewed in a neurodiversity paradigm as a normally occurring part of diversity in human traits. It also takes kind of this empowering stance in a way of recognizing that diversity of traits is an advantage to any system of living things, um, and that having differences in how we perceive and think and process is an advantage overall to humanity. So neurodiversity is something that you're going to use to describe a group, right? But there's neurodiversity within a group. Neurodivergent, this is coined by Kassian Asa Masa. That I always have a hard time with the name there, but um, this is a term that basically says that anybody whose neurotype diverges from the dominant social standards. So it's a really broad umbrella term, and in the neurodivergent community, oftentimes this can be used to describe both innate neurodivergences. So these are things that are more of kind of the neurological way that our brains are wired, and can also describe acquired neurodivergences, things like PTSD, um, things like yeah, PTSD kind of comes to mind, but it's a very broad umbrella, so a lot of things are kind of under this. In this talk, we're going to be talking about neurodivergence and mostly leaning into ADHD, autism, sensory processing, things like that. And so these are all innate neurodivergences, things that are part of the wiring of our neurotype.
Brittany, one of the things I love about this talk and like kind of pointing it out, and I think it needs to be said, and it's on the slide, but just recognizing that diversity of traits is an advantage to any system of living things. Like we
Mhm.
need this diversity of traits. And so that kind of fuels everything that we think about as far as embracing these traits and the human being.
Yes,
Yeah, just wanted to
absolutely.
mention that.
Yes. Thank you so much for highlighting that, and hopefully we'll see that as we continue through the presentation as well. That this is something where we're coming from an affirming perspective with our neurodivergent clients. It really does open up a whole realm of leaning and being more strength based when we're working with folks, and really being able to lean into those strengths versus thinking about it as a pathology and trying to change or fix or heal from something that is inherently part of how we process things. Okay. So speaking of that, we're going to just kind of compare the pathology paradigm to the neurodiversity paradigm. So a lot of times clinicians, we are trained more from the pathology paradigm. This is something that a lot of times our medical models are based on, our DSM is based on. And this views our differences as something that is there to be treated. Um, it's focusing more on the things that are impaired. And so you'll see things like deficits, impairments, language that kind of describes our traits as something that is bad or something that needs to be changed. And the treatment success looks like how close to neurotypical and conforming to kind of expectations can we look. And oftentimes this is not really super informed by lived experience, right? A lot of times this is informed by the dominant kind of more neuronormative ideas that there's a right way to act and to experience things. And then if we kind of switch into our neurodiversity paradigm, this is going to be viewed more that differences are natural and add value when embraced. I also want to kind of speak to the fact that that doesn't mean that it always works great, right? Or that it's always good. Because I think sometimes we can get a little black and white in that. And sometimes there may be conversations like, well, neurodivergent traits are superpowers. And sometimes they feel like that, and sometimes they might be. But that I think that we also need to acknowledge that there are also challenges that can come with neurodivergent traits. But instead of looking at that as something to be like fixed and changed, I think the neurodiversity paradigm will often look more at like how do we accommodate and work with and really try to boost quality of life and engagement in things that are important to us. Rather than focusing on impairments, there is more of a focus on unique strengths and also focus on like how do we accommodate where there's gaps or where there's challenges. The goals here are going to be to accommodate the authentic self. So success is more defined by the client and by the neurodivergent person than by what it looks like to be successful as defined by neuronormative society. And the neurodiversity paradigm really is kind of shaped by lived experience, and it has a very interesting history. So I really encourage folks, if this is something that piques your interest, to take a look into that more. Because it really did start at the grassroots and has been very much informed by neurodivergent people through the entirety of its existence. So really interesting history.
Brittany, that's another good example of how lived experiences inform science.
Mm-hmm.
I'm just over the year.
Yes.
Any talk, it was like lived experience, man. But it's really
Yes.
that grassroots energy has really changed things.
Yes. It is. It's so cool. And it's so exciting to see too, because I think we're in a time where there's so much more awareness of this and a lot of I think that I'm seeing more and more like autistic people, ADHDers, people with a combination, really being part of research, if not leading research and being, doing these really cool things that it opens doors in a way when you think about it from this other angle, and it really does create more inclusive conversation. So really cool. Okay. Um, so pathology paradigm is kind of it. If you look at the history, there's a lot of history here that there's no way I can cover it in a decent amount of time. So to really try to summarize, I think the main things to kind of take away here is that a lot of history with treating autism has been very focused on like what's the cause and is there a cure and how do we cure this? And that this is something that has first appeared in the DSM-3, has had revisions. Here we are. But also just kind of keeping in mind that this has historically always been classified and approached as a deficit, and kind of normed and measured against like what's the normal way to exist versus what's a normal way for an autistic person to exist. That might be a more helpful question when we're thinking about these things. So when we're shifting into neurodiversity paradigm, we are also putting on our critical questioning kind of mode, right? Where we're kind of keeping in mind that these diagnoses exist in the context of politics and society and all of the things that that are going on socially, politically, historically when the DSM is written, right? And so we have to remember that historically, who determines what is disordered? People with a lot of privilege, oftentimes, right, and people who may not have lived experience. We think about how these things have determined how we decide what's normal, what's healthy, what's the right way to be, and that these things have been influenced by the context. So we talked a little bit about neurodiversity, neurodivergent already. Neurotypical is kind of the probably more common neurotype. I don't know. It's also, I've heard it said that sometimes we can think about neurotypical as how closely does one align with neuronormativity. So that's kind of an interesting way to think about it as well. And neuronormative is a concept that talks about the tendency for our society to view being neurotypical as the more normal way of existing. And then neurodiverse, again, is a way to describe a group. So you wouldn't describe an individual as being neurodiverse, you would describe them as being neurodivergent. Neurodiverse would be a group of people.
I can't wait till we just stop using the word normal.
Right? Exactly.
Sure, we will stop.
Yes. Okay, so we've laid some groundwork here on just like what neurodiversity is. Now we're going to talk a little more about autism. And this is when we're looking at autism specifically, a lot of, if we're doing neurodiversity affirming, we want this to be driven by lived and subjective experiences of autistic people. We talked a little bit about identity first language already and how that comes into things. This paradigm will question and dismantle some of the stereotypes and stigma associated with autism. It is seen to be a neurological difference that's a natural and valuable part of human diversity. Again, not to say there's not challenges there, but there are many strengths as well. The goal here is fostering the creation of a positive and affirming autistic identity, along with increased understanding of needs and traits. And later in the presentation, we're going to talk a little bit about groups. And this is one of the things that I think can be so beautiful when we have programming that is very much designed for neurodivergent folks. Is that there's this like sense of community that I've really been able to see kind of blossom in our clients when they have this space together. That is so cool, and really does foster this like creation of identity and culture and things that are really special and really important, I think, for well-being and treatment and beyond. Okay. It values the lived and subjective experiences. Okay, so this is actually the same thing. So we will continue on. Okay, so in addition to these paradigms of pathology and neurodiversity, there's also a medical and social model of disability. These are also, really, really like these concepts and encourage you all to um, dive into this more because there's some really cool books out there, really cool advocates out there who are talking about these things. And it's such a refreshing way, I think, to think about and conceptualize disability in general. But then we can apply it when we're thinking about neurodivergence as well, right? And so in the medical model, again, this is where a lot of our training probably comes from. A lot of society thinks about disability from this way. And this is often what they say is disability is caused by deficits and pathologies within the individual. So medical model kind of says like, well, there you have something wrong that's going wrong with you, and you need treatment for that. Versus social model of disability. And this model says that disability is caused by the environment failing to accommodate needs and differences. And I think that can be when you are working with neurodivergent clients, and I think about times in like our FID process group where we've talked about this as a group together, in Recovery Unmasked, which is our neurodivergent group, where we talk about this with clients all together. And I can see like light bulbs clicking for people. It is the coolest thing when people start to go, wait, like, what if I'm not wrong? Like, what if there's not something inherently bad about me? What if my environment around me just didn't know how to appropriately meet my needs? And what if my needs were valid this whole time, right? So it opens this world of like reducing shame about these things that is just it's so cool to watch. So I really do encourage providers, if this piques your interest, like dive in. There's so much cool stuff, and it really does add just this deep context for clients that can be very, very powerful in the work that we do. Okay, this is just a little, I won't go through all of this because there's a lot of words on this slide.
I
This
love
comes
this
from,
slide though, Brittany. I
I
think it's
love
so
it. I do
interesting.
too.
I know we talked about it. I was like, keep it, keep it. I
We're
think
gonna
people
keep
will,
it.
yeah, I think people will love it.
I have to credit Matt Lowry, who wrote this. He is an autistic psychologist who does autism assessments. And he also has a podcast that's really good. I definitely encourage you to check out his website because this is where this is from. But he wrote these strength-based autistic diagnostic criteria. So he kind of he does all these assessments. You have to say, do people meet the DSM criteria? And him being an autistic person, he was able to write rewrite the DSM to be strength based, which is so cool. So rather than having these like deficit words, you'll see different things. So it says criteria A, different social communication and interaction as evidenced by the following. Differences in communication. So tendency to go off on tangents, tendency to talk passionately about special interests, tendency not to engage in small talk. So you can kind of see how that is. And he's really funny too. So there's a little humor in it in a way, but also it's real. And anytime I go through this, I use this in our Recovery Unmasked group when we're talking about neurodiversity. And it's really interesting to see clients kind of like connecting with this and being like, yeah, I do go off on
My
tangents and I
favorite,
do
my
care so
My
much.
my total favorite is tendency to not engage in small talk. Like it's like
Yes.
people are like, why are we doing this? Why are we having a conversation about like the weather or like what color your tie is? Like they're like, it's like, and you're in
Yes.
the group and you're going, if you don't want to do that, That's okay. That's
Right.
okay.
It's literally in our group norms. Like I wrote group norms for our recovery and mass group, and it's like the norms are like be neurodivergent, basically. Like bring your vengeance, don't make eye contact, like just come and be autistic, be ADHD. It's really cool. So um but yeah, so you can kind of see, I don't know that for time's sake, I don't know that I'm going to go through this whole entire thing.
We can send it to
But
anybody who wants to see it.
yeah, definitely. And also check out his website because it's there. I do really like section D though. These traits cause other people distress. So instead of being like a lot of times
Love
DSM
that.
goes, where does this impair you in your life? And he is kind of tongue in cheek in a way and being like,
That's
these
hilarious.
actually don't cause us problems. It's everybody else
I love that
who's
so much.
distressed. So
That's funny.
and also E, it's not due to intellectual disability. So
Right.
like there are going to be times where there's overlap, but that's one of the, I think, misconceptions sometimes is that autism is always you're either a genius or you have intellectual disability. And I think that's a really good stereotype to kind of remind people it's not always true, right? There's sometimes, but not all the time, is there intellectual disability.
Mm-hmm.
Okay. And then here's another one. So this one's strength-based criteria for ADHD, and this comes from Reese Ramponi. Again, another wonderful provider who does a lot of advocacy and really does a great job of destigmatizing a lot of neurodivergent things. So um, okay, so we'll just kind of go through this a little bit too. So I think again, the difference here being if we're talking about a deficit model, it's going to be saying like deficits in attention and so when we think about the words like dynamic attention span, oh my goodness, isn't that ADHD, right? Like maybe can't pay attention to doing the dishes but can highly pay attention to something that's super interesting.
1000%. Yeah.
So again, probably not going to go through every single one of these, but just really want to highlight with these slides that when we change the way we think about and talk about and word these things, it's like a whole new world opens up where it's no longer like this is a problem, this is a bad thing, this is a deficit. And I think what it does is it invites us in to then say, wow, like look at these traits that you have and how can we utilize your strengths and how can we better adapt things to fit what your needs are, and to maybe like bridge the gap where there may be some challenges or there may be lower, like you need more support in a certain area. So that I encourage you to check out Matt Lowry and Reese Ramponi. They have some really cool stuff. But hopefully takeaway here is like we can talk about these things differently. It does make a huge difference for clients and reduces shame a lot. Okay. Just want to talk a little bit too about accessibility. This is something that touches so many areas of care, and it's healthcare, it's mental health care, it's getting your prescriptions at the pharmacy, right? This is like every layer of care. Accessibility things can come up and be very, very challenging. Um, and this slide, it says accessibility for autistic traits, but I think also for ADHD as well, there's accessibility challenges in different ways. So don't want to make it sound like it's only autism. So oftentimes when an autistic person, an ADHD or ADHD, the combination of the two, sensory processing, anything like that, if you think about interacting with healthcare, how many sensory needs are going unmet, right? We go into a doctor's office with fluorescent lighting and maybe a strong smell of disinfectant and um, trying to communicate what's wrong to our provider. And if we have a neurotypical provider, they may not they may not understand like our communication styles, or may struggle with um, kind of seeing eye to eye or being on the same page. So sensory things come up, communication differences come up, navigating the system. How much executive functioning do we need to make an appointment? Right? Has anyone ever tried to call their insurance and find out who's in network? Like, there's so many steps that can be significantly challenging for just in the systems alone, right? And then that's not even talking about the fact that we also, as providers, do exist in society that is ableist, right? And a lot of times may have internalized ableism, may have biases that we are maybe not aware of or varying degrees of aware of. And so with autistic people, with ADHDers, a lot of times providers may just assume something about people's skills, abilities, needs, may kind of go, well, and I can think about it even with our field, for example. Um, Sometimes we can eating disorder treatment can kind of lean into behavioral things, where providers can go, well, we need to like shape a behavior by like the way that we respond to things. We don't want to enable people to do X, Y, and Z. But that if we're dealing with someone who's neurodivergent and we're applying like these neuronormative standards, it's really hard. That really creates a barrier to accessibility of care. And so that's something I think worth just being aware of, and hopefully plant some seeds in terms of thinking about these things. And then in addition, there's some interesting research out there about like kind of health outcomes for autistic people, especially. But you'll see that people often seek care later in a disease progression, probably for a lot of these reasons, right? And then maybe coming with more intense symptoms. Um, People are more likely to be labeled treatment resistant in eating disorder care because maybe they're having barriers and challenges that are coming up. But if we're not understanding what their needs are, it can look a lot like resistance, or it can be assumed to be resistance when, if we get curious about it, it can really help us understand more that it's coming from needs that are not being met. Um, and Oftentimes our standards of like eating are also derived from what's normal for non-autistic people, because sometimes maybe autistic people really need sameness, right? And need routine and need things that might be labeled as like rigid but actually are very regulating for their nervous system. um and we have the double empathy problem. Again, so much cool research coming from autistic people. So double empathy problem talks about this challenge that arises when we have neurotypical and neurodivergent people trying to communicate with each other. And they find that when we have like pairing neurotypes together that are the same, understanding increases, rating of like how much do you like this person increases. So turns out it's not a deficit. It's just a challenge with communication. We live in neuronormative world though, where a lot of times it's kind of put to the neurodivergent person to come and meet the neurotypical communication standard. And then suicide, also just really want to highlight that suicide's a very prevalent thing for neurodivergent people because there's inherently challenges and traumas and exhaustion. It's so deep in terms of how much there is trying to exist in a neuronormative society when you are a neurodivergent person. And so suicide rates are higher for neurodivergent people. Okay. Also, just I think this is so important for us as providers to be aware of too, that there are many common medical conditions that also tend to overlap, especially for autistic people, and can absolutely show up in treatment. And so just a few: mast cell activation, hypermobility, Ehlers-Danlos, GI things like irritable bowel, Crohn's disease, stuff like that, autoimmune diseases, delayed onset sleep disorder. Oh my goodness, so many night owls in the neurodivergent community. Um, Dysautonomia, POTS, nervous system problems, see that a lot. Endocrine disorders like polycystic ovaries, endometriosis, chronic pain. And so these are things that impact quality of life, but also impact eating disorder treatment. And I think it's so important that we have, if we're working with neurodivergent clients, that we have at least some baseline of like, okay, I know these things can happen, even if you're not an expert in it. So that way we're not minimizing or not acknowledging some of those experiences. Okay. Also just highlighting here that the research really does show that people who are assigned female at birth are often higher in the masking, and masking is this process of hiding our traits, right, and trying to appear to be neurotypical. And a lot of times this may also be related to kind of how AFAB folks are socialized in life. And so sometimes that will create situations where when an eating disorder provider is working with somebody, um, and maybe doesn't have as much knowledge about autism or ADHD, um, masking, it doesn't just happen out in the world, right? Like masking happens in treatment also. And so that may be an area where people may miss this and may accidentally, without meaning to, reinforce masking as like a good thing, and can be really tough for our neurodivergent clients, if especially if they don't know they're neurodivergent. But even if they do, um, knowing you're neurodivergent doesn't exclude you from masking or from the complications that come from masking. And then similarly for providers who maybe are really specialized in working with a lot of neurodivergent autistic ADHD clients, I cannot tell you, like, there's so many books sometimes that I'll be like, I'd really love to like recommend this to a client, but there's a whole chapter on like how your gut health is going to be like making things work better, and it's kind of in this like diet culture thing where there's like encouragement for restricting or for like eliminating certain food groups. And so I think there's definitely on both sides like deficits in terms of provider awareness of some of these things, and then we reinforce on accident, probably from both sides in different ways. Okay. Um, it is really important. I think this is talking about autistic traits, but I want to highlight also ADHD traits too, right? When we are trying to treat a client, if we are treating their traits, that is part of their brain and part of their perception and part of their identity, if we're kind of going into the identity first language that we've been talking about, it's very distressing and it can be very traumatic. And a lot of folks in the neurodivergent community have shared how traumatic that can be, to be basically treated and told like you need to change this core part of yourself, that probably is not changeable. Right? Like somebody may, let's take stimming for example. If we're treating stimming, we're probably not actually getting rid of the need for stimming to regulate your nervous system. We're probably just teaching people how to cover that up and mask it. And so this can be very, very traumatic. And when we're working with eating disorders, especially, um, I think it's so important in this intersection to really get curious with your client about, okay, is this ED? Is this your autism? Is this your ADHD? Because we're going to kind of approach it differently depending. So, and we'll get more into that when we do our case presentation. So I'm going to keep going. Um, just to try to keep us on time because we have so much still left to cover. Okay, masking. Again, this I'm kind of not showing my neurodivergent traits. A lot of times this is unconscious and it's done to try to stay safe in a neuronormative world. And a lot of times this can really cause a disconnect between like who am I and who am I showing to the world, which can be very, very, I mean, we could do weeks and weeks of therapy sessions on that, right? Like so much pain there that can contribute to the low self-esteem, feeling isolated, feeling like you don't know yourself.
And
Um,
that makes it almost, if you're consistently masking, then being connected to your authentic self and nurturing your authentic self, which is kind of the ground zero for healing from an eating disorder, right?
mhm.
Where does the person go? I think it's, you have a great slide here with a teeter-totter that shows some of that. So
Yeah, I can't remember where exactly that is, but it's
pop up.
coming up.
It's coming. We like our teeter-totter.
Yes. Okay. So just thinking about as providers, when we are treating our clients, keeping in mind like what happens when we suppress parts of ourselves, right? And how does this influence eating disorder? We could probably do so many summit presentations on this, but because it really influences it very deeply in a lot of ways and in a lot of angles of the eating disorder. Um, okay, so these are just some research points to note. Camouflaging compromises coping strategies to their hide behaviors associated with autism or purposely perform behaviors deemed to be neurotypical in order to socially fit in and avoid harm. Um, we also have studies that show that these are connected to both autistic and ADHD individuals, and that also people who are not autistic or ADHD can engage in masking to some degree. I think we could probably all think about times where we present ourselves in certain ways. But the difference being for neurodivergent people, a lot of times this is so deep that it's like psychologically, emotionally, physically, cognitively draining to a level that is very, very intense. And also can contribute to that suicidality rate being higher, which is one of the things we talked about earlier. Camouflaging, masking, these things are very psychologically and emotionally expensive things to engage in. And are there's a lot of consequences that can arise from spending a majority of your time in a state of hiding your authentic traits. Okay. We're going to talk a little bit about ARFID now because we see a lot of intersection here. I have been running our ARFID process group at Within since the day it was started. So I've had lots of clients go through the group and lots of people with ARFID share in this group their experiences and connect with each other. It's really such a special space. And something that's really important, I think, for us providers to understand, because the number of times I've heard clients say, like, this space is so meaningful because when I'm in other spaces around my eating disorder, people don't always get it. They don't always understand it. And there's maybe some uh, there's things that are not well understood. I think of ARFID as kind of like it's like a little niche inside of our eating disorder niche. So definitely encourage you all to, if you're working with neurodivergent clients, also do some work with ARFID. Because even for those with anorexia, even for those with binge eating, other eating disorders, ARFID-like traits are often present with neurodivergent clients as well. So just kind of having awareness of that. But we know that ARFID involves selective eating, right? There's subtypes of ARFID. So one subtype being sensory aversions that look like restricted food range. One subtype of ARFID looking like a fear of adverse consequences, right? So these phobias of anaphylaxis, vomiting, choking. One subtype of ARFID being kind of the low interest, so physical things. So that could be I don't notice hunger, I don't a lot of times I hear clients in ARFID process say eating just feels like such a chore. I can't tell you the number of times clients have said, I wish I was a plant and I could photosynthesize. It just feels like such a chore to have to do this. And I think that that's kind of the low interest ARFID. And oftentimes we see this, like all of those things in an ARFID presentation. One may be more primary. Sometimes we see two out of the three, but a lot of times you see at least some features of all of those different subtypes. And this is here's our teacher totter. I wanted to talk about this because I think across the years working with the ARFID clients here and in other capacities, what I see is ARFID symptoms. Like you kind of sometimes see this like ebb and flow with the symptoms in a way. And I think a lot of times that can be very, very highly connected to how much masking is happening, right? And we think about the things going on outside of the ARFID, like what are the social expectations? What are the pressures? What are the demands on your nervous system from a sensory perspective, from a communication perspective? Um, and these things can really create, because it is expensive cognitively and emotionally, it reduces then sometimes like the capacity for clients to feel like they can show up to do their exposures if they're doing exposures. Sometimes it's the capacity just to even adequately meet nutritional needs well. So if you are working with ARFID clients, especially ARFID clients who are also neurodivergent, I really encourage, if you're going to take something away from the ARFID portion of this, I encourage you to kind of think about ARFID as existing in this context of all of the other things that are also there. Because if we only try to prop up the ARFID with exposures and that's all we do, we're neglecting this other part of things that also deserve our attention. Because without addressing those things, if we're asking clients to do exposures, we're probably unintentionally causing some harm, right? And creating situations where they're now showing up even higher masking because my team wants me to do this, and also maybe don't have the capacity to do it. So I think that's really important. Okay, here are some. I asked our ARFID, both our ARFID alumni, I asked in alumni group and in our ARFID process group for clients to share if there were things they wanted for providers to know. So these are direct from direct from the clients. I would want people to know that ARFID can happen to adults too. It doesn't matter what age somebody is. It's not just for little kids, and it can happen in a larger body. The things I've experienced with other eating disorders, it feels like my mind is fighting my body's want for food. But with ARFID, it feels like my body is fighting against the food. It feels more out of my control. In the past, providers have sometimes been convinced that I'm anorexic. It felt like people were trying to diagnose me with something they could understand. I think it's so important to understand that ARFID comes in all shapes and sizes. I think a lot of people question if I actually have ARFID because I'm a girl and I'm in a small body, and they assume it's something else or that it's motivated by body concerns when it never has been. And even though the cause of restriction with ARFID isn't due to body image, it doesn't mean that we don't experience body image concerns too.
And Brittany, I know we've talked a little bit about this, and it's certainly something we're seeing in our programs that the DSM is just not accurate, that the two symptoms of anorexia and ARFID don't coexist. I really think
Mhm.
the second bubble, though, is something for us to all really kind of roll around in to help us understand. Not that one person's experience generalizes, but I love this piece, not love, but I take so much from this idea of like the with other eating disorders, it feels like my mind is fighting my body's want of food. But with ARFID, it feels like my body is fighting against the food. Such an
Mhm.
important such a really important distinction. And I do just want to say I'm really proud of what you do with our ARFID group. And I believe that our ARFID group is potentially one of the largest cohorts of ARFID patients. So for those of you who are out there listening that aren't familiar with the within, like not to sound like an infomercial, but it's, as you can see, Brittany creates this very special place and tremendous healing opportunities are happening here. So thank you, Brittany.
Thank you. I love that we have this here and have been able to build it. And the clients are the ARFID community we have here is just amazing. Like they're so supportive of each other. I only set the stage and then they do they do a lot of it. They are so awesome. So I cannot take the credit for what the clients have helped me create too. Okay. Um, I think this is you, Wendy.
Oh my gosh, it's my
Are
turn.
we here?
Oh,
Okay.
good. Thank you guys so much for being here. So before I say anything more, I also just want to do a huge shout out to my a collaborator in this talk that I've done in the past, Dr. Amy Boyers, who works with me at Galen Hope, and also we've worked together so much for years before that, and kind of come together with some of these thoughts. So I just wanted to shout her out. And so, as I was saying, and earlier in my career, there was really a lot of resistance that, oh, if you brought in patients with autism into your eating disorder program, you're sort of doing a no-no. But the reality is, where are these folks going to go? And so we just kind of within, we've put our bootstraps up and said, we're making this, we're changing the environment, right? That's what we're talking about the social disability versus the Medical Disability Foundation. So we want to make our environment work for our patients with both autism and ADHD. So here's some of the things that we just have to be very aware of. And it's super important because we do not want to be pathologizing aspects of patients like underlying just the way their brains are worth. And we don't want to misunderstand people. It takes an incredible amount of discernment to tease apart these issues. I would say it takes an incredible amount of connection. So it's really through the connections that we really start to understand one another. It doesn't matter if you have ADHD or you don't, but that its connection is really how we understand one another. But as we're going and thinking about like meal times, we want to be careful not to jump to conclusions and be punitive for folks going through different things. So, there can be social anxiety related to mealtime for folks. That's a little different than the social anxiety for those without autism and ADHD. So there can be communication differences that make eating the group very stressful. And so the person may just want to avoid or isolate. Stressors can be even conversations, the social rules and table manners that may or may not make, any sense. So some folks might feel a need or feel better with very specific set of conditions, and creating familiar and predictable environment. And I will say also that a big belief of mine is that, not everybody does get treated the same. So even if you have somebody with like, even not at within necessarily, but in other programs, if you have an ARFID patient and you have an eating disorder patient, eating at the same meal, which is the way many programs do that. I'm not necessarily the biggest fan of it, but it does happen, is to be able to explain to your staff and explain to patients, You all are different. So you might have a different set of rules, like you might have different boundaries, you might have different guidelines for different patients. So if we try to say everybody's eating at this table and everybody's expected to do the same thing, you're not being discerning, you're not really honoring the underlying person, who they are and how their brain works. So you might do things for folks with autism that you wouldn't do for another person, and that's okay. That's called good treatment. Rigidity in the face of complexity is toxic. That's a Susan David quote, not a Wendy Oliver Pyatt quote, but I love it. You can go to the next slide. So, so the sensory processing differences and difficulties can be really also a challenge. So, different reactions to sounds, difficulties with interoception. So lots of food on the plate, multiple components, different textures and flavors. This may really be something that can cause actual flooding. So the person's going to have different, responses to being overwhelmed in that situation. We also do see that there are some physical aspects of these conditions that may make things feel and behave differently. So there can be deterioration of the gut microbiome related to limited and preferred foods. So more GI distress or IBS type of presentations. There can be very high sensitivity to feelings of fullness, very high reactivity to intolerances of GI processes. And I've really seen this, and it's just like you just realize that the person is feeling this sense of panic and catastrophic reaction to feelings of fullness that are just different. Low muscle tone can also affect folks, and difficulties with fine motor skills. This is a really, really big deal. Can make feeding itself different. People sometimes might want to eat with their hands, or they may hold utensils in a different way. They may have rituals with the food, like putting food in the cheeks and things of that nature. There can be so many different ways that the person's like responding, and it is not, something to be pathologized. It's something to be worked with, and in some ways, it just requires an incredible amount of compassion and attuned responses. So this is why you need small milieux. This is why you need high frequency of therapy. This is why you need lots of contact with patients, because when we don't do that, we don't understand people, then we tend to, what we don't understand, we tend to judge. And then when we start judging, we're creating walls. So that's the point of understanding this. So the interoception concern, we were talking a little bit already about around that. And I think this group here in this presentation understands that and knows I don't need to necessarily explain there might be a different reactions to textures, smells, tastes. I mean, be a person with, ADHD and have that tag on the back of your dress or whatever, and good luck with that. But the other thing is bodily trust and feeling of safety with ownership of one's body. So needing more, like gravitating more towards external reinforcement or approval. And then there is also a tendency from these family dynamics with no blame whatsoever, but there can be a lot of judgment around the person over the course of their life, for the ways that they may be eating differently or the limitations in the food. So there's this judgment and sort of chaos surrounding the person when it comes to merely eating. And so, and then on top of that, diet culture can be even more internalized, or a person could take it in a more concrete way and not necessarily be able to discern it as readily and easily, depending on how the person's brain is just functioning and operating. So there might be a leaning towards highly palatable foods to reduce the interoceptive overwhelm because they're predictable, things of that nature. So we have to look at all this stuff going on with the food and not just be, my least favorite thing that I hear, Brittany, is that's your eating disorder talking. I don't even care if it is your eating disorder. Like, no, that's just a way simplistic way that's not help. Okay, next. So then there's the exteroception. So that heightened exteroception can be very overwhelming as well, like being very hyper aware of surroundings. Talk to somebody with ADHD about walking, in through a mall. I don't have ADHD full diagnosis, but I have traits of ADHD, and people just, my family, my kids, they all just laugh at me because you know, my girls used to laugh at me because I never wanted to go like to the mall and stuff. They'd be their friends were like their moms like, let's go to the mall. And I'm like, don't take me to the mall. Don't make me go to Whole Foods. You know, I need to go to a small little grocery store with dim lights, you know. But this hyper awareness of surroundings can make it you feel more just more isolated and anxious, or like you don't fit in as well. And so when you're feeling that insecurity, that can then trigger other pieces of ourselves that are trying to protect us, such as perfectionism and other personality characteristics, to sort of manage all of this chaos going on. So strong aversions to textures, colors, scents, taste. Anybody that knows me knows how I feel about avocados. Know me for a week and you know, like, don't put it. I'm at the Mexican restaurant. I'm like, no avocado. Like the texture of avocado makes me want to like, ah! You know, so it's a definite strong reaction to avocados, I must say. So we can go to the next slide. So again, we're just talking about this in general. And by the way, we decided not to do the slide that we had that would have given us the headache that had to do with when autism and ADHD are combined. But yes, that also happens. There are, you know, there's research to show that folks with ADHD do have a greater risk of developing BED and bulimia nervosa as well. ADHD girls are about 4 times more likely to have an eating disorder, those without. And so neurodivergent experiences in our society can contribute to the eating disorders, such as bullying or wanting to fit in or being accepted, other traumas. And I also talk about unmet needs being met. So we all have different unmet needs, and unmet neurodivergent needs are a whole nother layer of unmet needs. And we talk a little bit about the importance of belonging, you know, as we proceed on. We can go to the next slide. I've been really interested in ADHD and eating disorders since very early in my career. You know, in the field itself, it can be very controversial to know how do you treat folks with ADHD who are underweight or restrictive due to an eating disorder? Do you use stimulants and that sort of thing? And so I've sort of developed my own like sort of protocols around that. But certainly, you know, ADHD with executive functioning impairment can actually increase the chaos in general, the impulsivity that can trigger a pattern toward binging, which can lead to binging disorder or bulimia. And a big piece of the executive functioning issues are tied into prepping and preparing and being able to meet your needs, and just the practical execution of like what it actually takes to have food in your house that you are wanting to eat. So people can go, contrary to what many people think, folks with BED tend to be very restrictive in the first place due to internalized shame. And if they're in a larger body, internalized shame and weight stigma is incredibly overwhelming. So that, in addition to the executive functioning issues, is a recipe for binging, of course, because the body is responding to the deprivation. And then with anorexia nervosa, one of the other things is the way that you can get very ruminative or hyper focused as well. And then in the case of ADHD also, so often there's that learned helplessness where the person's just that whole feeling of ADHD. I keep trying, but I come up short. I'm trying, but mom's mad, dad's mad. I lost my homework again. I didn't know there was a test. I can't keep my room organized. I'm always sort of in trouble. I'm always letting people down. I'm never quite up to par. I'm just dropping balls. We talk about strong starts, poor finishers. So that deep sense of inadequacy, which is shame, but you know, an internalized shame, again, that is fuel for an eating disorder, because the eating disorder is a way to, in some ways, sort of feel like, hey, at least I have something under my control. And I remember one of my first very complicated patients, thank God she's doing really well now, but she had ADHD and OCD and anorexia nervosa. And she was going to a school that was just harder than she could manage. And so she always felt inadequate. And that OCD and eating disorder and combination, as sort of a response to the ADHD and the environment she was in was really, really tough. So a big piece of treatment of folks with ADHD and autism with eating disorders is getting into the right environment. Again, not trying to change the person to fit the environment, making sure the environment is the right place, moving the kid out of the school. That can be a part of treatment, and sometimes that can be really hard for families to hear, but it's incredibly important that people be in environments where they are leaning towards capable of succeeding. I could talk about this one for a long time, Brittany. That's one of my pet peeves. You can keep going. So there's some neurobiological, pieces going on here for folks with ADHD, and I mentioned it a little bit, and I don't want to spend a lot of time on it because we don't have that much time, but reward deficiency syndrome that has to do with insufficient dopamine, which can cause people to seek satisfaction through food. And I mean, GABA deficits, ADHD brains have lower GABA deficits, lower GABA levels. Executive functioning deficits also get tied into other aspects of self-care beyond just feeding and nurturing yourself. It also is tied in with like making sure that you have time off from work, planning your schedule so that you're not overwhelmed, saying no to certain things, don't just, without the filter being there or the break being there to navigate, then there can be this overwhelm and flood because the person really hasn't figured out like a routine or a way to actually be able to properly care for themselves. I also see a lot of issues in couples and relationships, sometimes with those with difficulties with executive functioning interpersonally, where the person may not be getting their needs met interpersonally. There can be shame or condescending kind of dynamics around that person that has ADHD or autism. And then the spouse or partner is kind of frustrated and sort of demeaning of the other partner. So there's a lot of dynamics that we have to go after. And we do really emphasize in all my programs always and forever, a huge piece of it is family work. And that can be family education, family coaching, and family therapy. So some of this work, I'm sure you do this, Brittany, is the coaching. It's the education and the coaching. It's helping families wrap their head around where their loved one is going to be successful and feel competent. Because if there's anything I say today, that's something I want to say. We have to help people be environments that work for them, not try to shove them into an environment that we like the idea of this school or that school or whatever. We can keep going. So with binge eating disorder, we said we're going to talk a little bit about that. There can be with the ADHD brain, the interoceptive awareness issues sometimes. If the person on ADHD meds, they could have struggles around hunger and fullness. By the way, that doesn't mean I don't use stimulants for these patients. I just use them in a very particular way. Sleep control, sleep issues which you see with ADHD, which you see with ADHD meds, can also, and talk about being tired and then talk about executive functioning, like they don't go well together. So these are just some of the things that kind of come up for folks. I'm trying to go really fast. So we talked about the dopamine, and so the low dopamine can look like poor motivation and obviously the difficulty concentrating and anxiety. And we didn't even get into the potential of self-medicating through other substances, which is also coming to play, which we didn't really get to. That's a whole nother talk, right, Brittany? We already talked about the low dopamine levels, and I think we can just keep going. So the ADHD and binge eating do involve similar brain processing reward circuits in the brain, like the dopaminergic system or impulsive behavior you see in both conditions, and processing emotions, difficulty processing emotions. Slide. So some experts believe that ADHD and BED are connected because the ADHD leads to challenges with impulse control. We already talked about that, and reward circuit. And so that is why it is so important to do the education part and to work on the internalized shame. When you've got somebody with ADHD, you can be sure that they have internalized shame because of always feeling like they've come up short. And then your care is going to have to be really directed towards enhancing self-compassion and really checking in a very specific way around self-care. And another piece of it is, again, addressing the learned helplessness, where the person just, I try and try and try, and I'm just not getting anywhere, that any one of us would feel that way at some point. Next slide. We talked about this, but I want to just mention, I mentioned already the brain, the biological system, and the psychosocial system, where the interpersonal needs may not be met. I'm not good enough, like I've never succeeded, so I don't deserve. And then being treated maybe poorly interpersonally, and that also intrapsychic shame pathway activation, like I'm not doing enough, therefore I'm a shameful person. This is really deep stuff. And when you're doing the work in therapy, it is so cool to help people see this in a more objective way and see it for what it is, and develop that self-compassion and those little step-by-step little pockets of self-care and self-compassion are really, really fun. And you may have to be very proactive. I'll just say to the therapist, you may have to be very proactive. Don't be passive. Be very proactive, in my opinion, in helping folks start to take these steps. Don't just talk about this. Like, that's why we have care partners, and that's why we practice things in real life. If you're doing outpatient practice, I encourage you to be I actually encourage high specificity around working on some of this stuff. Like, it might be getting a manicure, pedicure. No blank slate here. No, no, no. You're going to be doing a little reparenting here. So, Brittany, you're nodding your head. It sounds like we're on the same page with that. We can go to the next one. This is just some stuff about treatment. I did mention I do use medication for eating disorder patients. And I generally am assured that if they are underweight, they're at least at 90% of biologically appropriate weight in order to use a stimulant, and all kinds of different therapy processes. I will mention interpersonal therapy as a big time one for ADHD and BED. Many of these patients have so much freaking trauma. They have trauma related to feeling they've come up short. They have trauma related to something blatantly that happened. They have internalized weight stigma. They have low self-esteem. And there's so many, and EMDR is one of the most well-studied components of treatment for trauma, and highly underutilized in our field, in my humble opinion. So next slide. So a little bit about mindful eating. I don't want to take a lot of time on this, but I don't believe that it's true that, oh my God, people who are neurodivergent, can't learn how to do a mindful eating. I don't actually believe that. And I think with all of our patients, every one of our patients, and myself included, when I had my own eating disorder, it really comes down to kind of a blend and a process, a developmental process, where you kind of have to, if there's a Venn diagram, which another talk, I just made this Venn diagram with Sean about mechanical eating. There's a little bit of mechanical eating, some intuitive eating, and some mindful eating in there. And so with a person that's like more interoceptive awareness struggles, or just not able to tap into hunger as much or fullness as much, there might be more mechanical eating. There might be some need. And again, mechanical eating isn't just like, we don't say, oh, I'm Wendy and I'm the psychiatrist, therefore you go ahead and complete that meal. Mechanical eating is really grounded on a relationship that's built on trust. So it's sort of helping, let's say it's you, Brittany. I'm saying, Brittany, like, I really want to help you. I feel like it might be difficult for you to manage this right now. So can we work together in a trusting relationship where I'm going to sort of help you figure out how much you need to eat for a while. Later on, you're going to figure this out on your own. And sometimes I use sports analogy because my kids all play basketball. It's like, I'm going to hold the ball for a while, and then I'm going to pass you the ball. You can pass it back. But it's a blend of all of these processes that help people go forward. So there are some greater tendency towards, all of our patients have different reasons why this can be really hard, but thinking of it as a developmental model and thinking about blending mechanical, intuitive, and mindful. And you said it too, Brittany, like, people are going to have pops of, like, when they're less masking, you're saying there's more room for some of this stuff, right? So as you're working on these issues, and I would say also in the group experience, there's ways that we're helping people heal. that then gives them sort of pops. And then if they even have a pop, you're like, whoa, look what you did yesterday. They may then retreat and go back 20 steps. You're like, wait, we just went 5 steps and now there are 20 steps. And that's okay, but you're going to still remind them, hey, you did those other steps yesterday. What was going on that made that possible? How did that feel? Next slide. This is just more of the same. Is just I want to just say that's very important to not go too fast into pushing forward intuitive eating or mindful eating, and because you can send the message of like if you give out too much rope, like people may push for it too. I'm ready, I can do it, la la la, which we want to listen to that and respect. But you have to pay close attention because if you go too fast, you're sending them. You could send the message like you're fine, you're okay, you don't need me, and that's not really very possibly that's not what the person may or may not be ready to hear that. So you can go to the next slide. Mindful eating with all patients, not just neurodivergence, is really about doing one thing at a time, understanding around guilt and binge eating, dealing with trust, relearning your relationship with food, and then thinking about how executive functioning is going. I think we're going to hand over to you now,
To
right?
me.
I think
Yeah.
we only have 10 tiny
I
little minutes.
know.
Do
So
you,
I'm thinking I may do the case study just to kind of talk
I
about
think
this,
that would
but
be a good idea. Yeah,
yeah, I think that's what we'll do.
yeah.
So I will just like quickly also highlight that for a lot of the reasons we talked about already with like this experience of being neurodivergent, there's also a very high overlap with autism and anorexia. And this is, I think, if we're going to kind of like summarize it in a one liner, what I would say is it's probably a combination of autistic traits that kind of can really latch on to eating disorder presentation
Mhm.
and symptoms, in addition to this underlying experience of being kind of othered and different and bullied and kind of the trauma experiences that go oftentimes hand in hand with existing as an autistic person in a neuronormative world. And so I think when you are treating autistic clients, I really, really encourage you to like do some reading, not just about the intersection, but really lean into learning more about autism. There are so many wonderful, wonderful resources and advocates. And I would also encourage you to learn from autistic people who are out there doing the advocating, because you will find that like you'll learn about certain traits and you will probably be able to make a connection of like, oh, well, I kind of see this happening in my eating disorder clients, right? And so I would really encourage, like, this is something that even if we had all the time to get through all of the slides, it would still be very surface in terms of like, if this is interesting and if you have autistic clients, I really encourage you continue, let this be a starting point for you in terms of learning these things and go deeper into it, because there's so much wonderful resources out there to learn from. Um, so Wendy, did you want to talk a little bit about groups real
Yeah, we
quickly
we
before I
only
do
have
case
seven.
study?
Yeah, really only
Okay.
7 minutes. But one thing that we really feel is important is creating, fostering belonging, and then but with belonging, you have accountability, hope, and connection. Especially if you've been feeling othered by the outside world. And Brittany's going to
Mhm.
talk about her case presentation in 7 minutes flat, and also about some of the amazing, amazing work being done in the group. And I do believe the group setting where folks can feel a sense of belonging and safety, I think it's incredibly powerful for us
Mhm.
within, and a really special space.
Yes, I agree. Okay, so I will do a quick case presentation, and this is a client. Um, I'm going to kind of read through the demographics. So this client is a 29-year-old cisgender woman with using she, her pronouns. She lives in an apartment with her roommate. She's white, queer, and agnostic. and was diagnosed with autism and ADHD when she was 25, so about 4 years before starting treatment. She presents to care with symptoms of restriction, compulsive overexercise, calorie counting, and reports texture sensitivity with certain foods. Clients experience a long history of eating disorder symptoms with restrictive eating, onset during middle school, and previous treatment at the outpatient level of care. Upon admission at Within, um, she had reported that her symptoms were taking up about 95% of her day, so pretty intense eating disorder symptoms. And she was admitted at IOP level of care after she had had a relapse in her behaviors that were not responding at outpatient level. Okay, so I think what I'll do is I will share and kind of talk through some of the outcome measures with while I talk through what was going on with this client. So I removed the dates on these just so that to kind of really help try to protect confidentiality, but just know that each of the marks were taken about a month apart. So the first one being like her initial um, scores and then each month in treatment. So as you can see, she has very elevated EDEQ scores, definitely clinically significant EDEQOL scores, intuitive eating. I mean, not the worst, not the greatest, and very high depression scores as well as high anxiety scores. And so she came in with these scores, and she was in our care for about a month and ended up having a change in treatment team. So she came to me at about this point, the second point on the graph. And she was at that point like, I'm so over this. I'm ready to leave treatment. Like, this isn't working. I'm so tired. This is too much for me. And we started to lean into exploring this intersection with the autism, ADHD, eating disorder symptoms. So, one of the first things that we did was started to get curious about what's happening with this informed perspective. And she was able to identify that she was getting really stuck in these attention tunnels. So, she was working from home and would get very, very stuck in a work project. And that's an attention difference, right? Probably for both autism and ADHD, these things can happen. And when she was really encompassed in work, what was happening is that she wasn't recognizing hunger. It was very hard for her to transition to eat something because then she'd be so scared that she would forget what she was doing and not be able to transition back to her work and get the work done. And so what we did in treatment to start with to address that was choosing foods that were accessible to have just sitting right there at the desk so that there was no transition needed. There was just kind of like taking away some of the shame and stigma and saying like, okay, like if you can't prepare a whole entire meal right now, what can you have that will meet your nutritional needs? And that was really cool. And we also started to explore some of that compulsive movement because we made these connections, understanding that like the movement, while kind of assumed to be eating disorder related, was also at least partially sensory seeking for proprioceptive input. And she had said in our session, this is a quote from one of our sessions, I've told other people before, but they think I'm crazy. Sometimes I need to do movement to make sense of where my joints are. And I was like, hello, have you heard of proprioceptive input and vestibular input? Because that's a lot what that sounds like. So with these changes that we made, just making food more accessible, like she very quickly was like, I'm eating more consistently now than I ever have in the past year. And so just the minor changes even were very, very, very impactful. We also during this time, so you can kind of see this very big jump here with a lot of the improvement happening. And so we also were able to identify some like ARFID traits that were present. which then allowed us to add her to the RFID table, to the RFID process group, building community. And she had successful treatment complete within 4 months of starting treatment, which I think was just such a cool thing to see. So I chose this case presentation. Not every single case is going to be that straightforward. Let me just say that. But I thought that this was such a beautiful illustration of like data that shows when we are able to meet a client's needs and accommodate their neurodivergent traits, it opens doors in ways that like feel very stuck if we're missing that really important part. So
Brittany, I love how you got very specific with her about what to do with the food, so that was available. I remember one of our first ADHD BED patients that we treated, she absolutely refused to eat on camera because we eat together on camera, and she was like, I remember calling Sean and going, Sean, we're going to admit this patient, and we're not going to make her be on camera at first. And it actually, she had about a 6-week stay, and she did so well. She ended up leaving Florida and going to New York and getting some really nice red lipstick too.
I love it. I love
Yeah.
it.
Anyway, I
Yeah.
know it's 3 o'clock, Miss Jane.
We're right on the hour. So
Guys, nailed it. I mean, literally, it is 3 o'clock, and I am so happy to say that that is the conclusion of our 2025 Within Health Summit. Thank you all so much for hanging with us, whether if you just joined for one day or if you were with us for all 4 days. We appreciate you. You guys are getting so much love in the chat. Just beautiful job. They're saying thanks, Brittany. Thank you, Wendy. Just the love is overflowing. Just final thoughts. Again, thank you. Do not forget to visit your CEGO dashboard. You will be able to complete your evaluations. Please give us your feedback. We value your input, your comments, your questions. I will also put my information in the chat again, just in case you missed it. If there are any other questions about the summit regarding certificates or any logistics, please reach out to me directly, and I will be happy to navigate those things with you. Any closing thoughts from my amazing colleagues?
Brittany, what do you got to say?
um thank you. This is I love sharing all of this and so appreciate all the participants as well. What a cool thing that
Yeah.
a lot of people want to learn more about this. I think that that just like fills my heart with hope and joy.
And I'm grateful that you're doing the RFID alumni group. So our folks that come through our program are going to have a place where they belong and connect even after treatment. I think that's going to be an incredibly meaningful experience. And I'm very proud of Within for creating the alumni program. Jamie, you had a lot to do with that. And that RFID alumni group is going to be a really beautiful,
Mhm.
safe space for folks. So if anybody has any patients out there that are alone dealing with these kind of presentations, we do really try to take that care of them with so much
Mhm.
attentiveness. As you can see, Brittany is so passionate, incredibly grateful.
Thank you, everybody. Have a wonderful weekend.
Thank
Bye-bye.
you. Bye everyone.
Bye, everybody.